Okay, I think I'm going to get started. So thank you everyone for joining us today for this seminar. My name is Maggie and I'm a member of the UHN Research IDA Committee. And I wanted to start this session by first acknowledging the land on which UHN operates. There has been a UHN hospital on this land since 1829, and long before that, Indigenous people were its stewards. They, as their descendants, and we at UHN do now, learned, shared knowledge, and healed each other. Ontario is covered by 46 territorial treaties and agreements with First Nations, Métis, and Inuit people. Regardless of where we sit today, we owe much to the peoples who have called this land home. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. And today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to live here. We remember and honor the legacy of the people who have been here before us and all who work to make the promise and the challenge of truth and reconciliation real. And I would like to invite you to join me in taking a moment to reflect on the land that you are on, wherever you may be. And now I'd like to invite Dawn Weaver, the director of the Krembil Research Institute, to introduce our speaker.
Good morning and welcome. The coronavirus pandemic has really forced our hospital and most of the healthcare institutions, not only in Canada, but around the world, to divert an incredible amount of our effort towards treating people, not only those infected with the virus, but also preventing the continued spread of this infection. And because of this, we really have had to reduce a lot of services, in particular in-person visits, to try to mitigate the spread of COVID-19. The impact of this has really been quite significant. And one of the groups that has been tremendously impacted are the 15 to 20% of Canadians who struggle with chronic pain. They've lost their access to resources like routine physiotherapy, psychotherapy, and a lot of the resources that were crucial in helping them live a life and coping with their pain. So today, Dr. Hans Clark is going to share some of the interventions that have been pioneered at UHN to address this important clinical gap, with a particular focus on the new models of care and novel interventions to improve access to care during the pandemic. And, you know, in the long term, we're going to find out that they're going to stay on long after this pandemic. His talk will then conclude with an overview of some new clinical and basic science research on cannabis that's underway at UHN. So for those of you who don't know, Dr. Clark is director of the Pain Services and the Pain Research Unit at the Toronto General Hospital and a clinician investigator at the Krembil Research Institute at the Toronto Western Hospital. Dr. Clark is also the Knowledge Translation Chair for the University of Toronto Centre for the Study of Pain and an associate professor in the Department of Anesthesiology and Pain Medicine at the University of Toronto. So as a clinician investigator at Krembil, Dr. Clark has played a leading role in educating the public about pain control, alternatives to opiates, and the need for further studies on the beneficial and adverse effects of cannabis. He's certainly a champion of evidence-based solutions for the opioid crisis and an advocate for a national pain and addiction strategy in Canada. He's authored more than 100 peer-reviewed publications and has been invited to speak on pain control, the opioid crisis, and cannabis use to a wide variety of audiences, to the House of Commons in Ottawa, across Canada, and indeed widely throughout the world. And so with that, it is my pleasure to turn the presentation over to Dr. Clark. Dr. Clark.
Thank you very much for that introduction, Dawn. And I'd like to thank Maggie as well as Azadeh for inviting me to present to everybody today at the Equity, Diversity and Inclusion UHN rounds. And what I hope to do is to take you through a bit of a journey from the development of this program to where we sit today. And as Dawn said, talk about some of the highlights in terms of what we've been able to do during the pandemic and hopefully where we're heading over time. Before I dive into everything, I'm going to just present my disclosures. There's nothing from the program perspective or when we talk about the opioid and pain care that has any commercial interests. At the end, when I do present some of the work that we are doing with association with the Shoppers Drug Mart folks, there is obviously a commercial interest there. So before I dive into the content, I think, pictures like this are 2020 was a historic year for many reasons. And Dawn touched on the COVID-19 pandemic, but, the Black Lives Matter movement and the famous knee on the neck certainly started another revolutionary movement when it comes to the focus of anti-Black racism and looking at kind of society in terms of the historical use or misuse or problems associated with Black individuals and in particular healthcare. And so I do know that I saw Karen Davis on the screen. She is the president of the Canadian Pain Society. I have just become a board member of the Canadian Pain Society, and I wanted to let everybody know about this webinar that many of you may have missed. And so it sits with the Canadian Pain Society. It's on the social inequalities and pain, and somewhat about the untold stories of Blacks and chronic pain. And so we had three tremendous speakers. Daniel Buckman is our ethicist from UHN. I think he's since moved on to St. Mike's. Akwasi is a friend of mine and a sociologist at U of T, and Carmen Green is an anesthesiologist south of the border. And I have the link there for any of you that would like to just take a look at this webinar. It was well attended. It was probably one of the best attended, over 100 plus individuals. It was sponsored, and in part I put this up by our research here at UHN. Brad did sponsor this event, and so we were thankful for that. And really it covers just a sneak preview, things like the dehumanization and the superhumanization concepts and how they are still rampant in today's society. You see there a picture of LeBron James almost classified as ape-like and superhuman, which is often associated with some of those aggression type stories when some of these police officers are speaking to the grand jury, talking about how strong these individuals were that they were fighting. And you can obviously see some references to the ex-president of the United States there in one of the Belgian newspapers not too long ago. So with that being said, let's focus on the other vulnerable population, which are our chronic pain patients and our patients that ultimately end up with a potential problem long-term when it comes to a consequence of something perhaps that was life-saving. So something that, when we look at our center, we are Toronto General in particular, we're a big cardiac center, we're a big transplant center. And lo and behold, in 2014, when we built our program, we had no pain program here. There was, and there continues to be, a very strong pain program at the Toronto Western. We have the Toronto Rehab folks who are doing pain and physiotherapy type work, but there was nothing institutional at the TGH site until we built our program in 2014. And so, this term of transitional pain care or transitional care has morphed so much in the past 7 years. And I can tell you that when we talk about this concept of acute to chronic pain, which is what we built this program around as its pillars of research. So lots of work in acute pain, lots of work in chronic pain, but we're still a bit mystified as to who goes on to have a chronic pain problem as a consequence of an acute pain issue. And for the most part, 85 to 90% of people do not go on to have a chronic pain problem as a consequence of an acute pain. But rest assured, we have big cancer programs. There are people developing chemo-induced neuropathy daily. Those symptoms may never go away. Rest assured, people are having surgery to remove their tumors or elective other types of surgeries, and nerves are being nicked. And some of these folks end up with a pain problem that persists for the rest of their life. And so certainly a gap that was identified and we were going to try to close. The transitional piece in terms of the adolescent to adult piece has been picked up from the Toronto Academic Pain Medicine Institute. We have this whole hospital to community point of transition where there is a lot of money out there in terms of looking at how we do this more from a mobile or a virtual standpoint. I've been in touch with some private healthcare institutions that I think are already potentially discussing some of these potential plans down the road, given that we may continue to land in this virtual space. One of the things that the government really liked was our possibility of monitoring these folks that leave hospital on opioids and being able to be kind of an opioid stewardship that we've become for some of these folks. The transition off of high dose opioids onto drugs like Suboxone and buprenorphine are something that we do routinely nowadays. And this whole concept of medication cessation. And so, Rob Tanguay, one of my colleagues in Alberta, has coined the first, opioid deprescribing program. And patients don't like that term, and for obvious reasons. And I can tell you that this has become a lot of what we do in the pain world in terms of helping people come down off of specific doses of medications that may or may not be as helpful as we once were. But how did we get into this problem? And I can tell you that, you know, this perseverance on bringing someone's pain number down has really been the bane of our existence. And so in the acute pain setting, yes, we'd like to bring your 9 down to 0, and we'll do our best, and we'll give you whatever medication we need to do that, perform different blocks. But over time, when a pain becomes chronic, you will be living with this pain, and promising folks that we can eradicate that in the chronic pain setting has been an issue. And I'll tell you, I have patients that will come into my clinic and they will tell me that, Dr. Clark, you and your team have done nothing for me in the past 2.5 years, and I don't even know why I keep coming. And then I'll say to the patient, well, aren't you the same person that was coming in your scooter and you rode your bike in today? And so yes, your pain may well be the same, but I think I can argue back with that individual that your life looks a little bit different in that 2.5 year journey at the pain clinic. And so one of the things I stress to my patients from the time they come into our program is, look, this is something you may well be living with. And we see folks that once they start down this journey, they're 8 years into a journey of trying to figure out how they can eradicate their pain. And to be honest, it's just sometimes a bit of fool's gold. And so I will always tell my patients, if we can keep your pain stable and your functional improvements heading in the right direction, we're actually winning the battle. So that's the pain side of things, and that's pretty clear. Unfortunately, the funders aren't so interested in pain. And let's be clear, $650 billion are spent in pain in the US. Our number in Canada is about 47 to 60 billion. And what we were seeing, and this was just right, I picked this up, it's a 2010 paper, but this was sitting right in the front, the front area of the Fraser Elliott side of the building. And it was a prescribing of opioids after minor surgery that can lead to a 10% addiction risk. And, you know, we don't really use the term addiction anymore. We call it opioid use disorder. And there's no doubt that that number is a bit high. The honest number for all comers that, you know, we do 200 million surgeries plus worldwide a year, is probably 1 to 2% that may be on their opioid-based medication. But this, obviously, there was the height of the opiophobia, so to speak, and this really stuck, and people really started to look at what are we doing from the perioperative standpoint in terms of increasing the risk of individuals persisting on their opioids. And so again, probably 1 to 3%. But here is some data that we published in JAMA in 2018. Actually, Dr. Latta did, one of my colleagues. And you know, if you take a patient that's walking into any of our institutions and they are on 0 to 50 milligrams of opioids, their risk of potential overdose or at about 90 days is almost next to none. But if someone walks in on 50 milligrams or 100 milligrams plus, which really is about 20 milligrams of hydromorphone when you think about what the doses some of these folks are on, one, we often escalate them 2 or 3 times in hospital. They leave. There is no real recourse until we built some of the program that we have put together to close the gap in these folks. And their risk skyrockets from almost 0 to 142 per 100,000 surgeries that are being performed. So again, we'd like to change the system. We want to create the Cadillac, but does everyone need the Cadillac? We still have to identify those people at highest risk of going on to have a potential negative outcome. And that's certainly what we did with the development of our transitional pain program. I'm highlighting this slide because we're about to give a series of rounds to the surgical community about new elective surgery prescription discharge medication consensus statements that we put together. This was a good 2.5 years of work we did with the best practices of surgery folks. I think I present to the otolaryngology department this Friday, and in March, we're doing it to the greater surgical community. But this got buried. It was published in March, a week before the COVID lockdown. And so we do think we have to bring this back out, and it's simply speaking to no longer having standardized prescriptions that you often see, you know, sometimes in some hospitals, before the patient's asleep, their discharge opioid prescription has been written. And you know, ultimately, one of the leaders in the acute pain world is a guy named Stefan Shug in Australia. And in Australia, you must actually take a look at what a patient used from a pain perspective in the 24 hours before they leave hospital, before you actually write them a script. And if it's not within 10% of what that patient was using, they actually don't get that prescription. It has to be rewritten. And so simple things that we can talk about in terms of taking the the onus off of ourselves in terms of not being responsive to this potential problem. Okay, so when we started our transitional pain service program, we really highlighted individuals in the post-op setting in those initial years. At first, members in the healthcare team were like, what is this? What are you doing? Our patients don't have pain. And of course, roll forward to today, and we see 20 to 30 patients on a daily basis come through the clinic dealing with, some type of pain issue that is a consequence of some type of intervention quite often. And it's moved from that acute pain setting into the post-op settings. The surgeons are very aware and understanding of their patients that may need help and asking for repeat prescriptions and things of that nature. And we get those referrals pretty routinely. I will tell you, we are probably the only pain program in the province that will see a post-transplant pain patient. Docs like to take care of the simple types of scenarios. And when we talk about our transplant patients that are on multiple medications, et cetera, they routinely land in our care. And it's a resource that I think is somewhat under-recognized. From the pre-op perspective, we all know those individuals based on the risk factors that have a high predisposition to potentially having a persistent pain problem or a persistent opioid problem long-term. Just trying to find my mouse here. Do it that way. So we had some, relatively good press about the service. Really, you need specific individuals, and the hallmarks of pain care is clearly not only the medication management, which is the easy part, but it's that psychological component whereby which those patients that are struggling from their antecedent adolescent and childhood issues, whether it's a history of sexual abuse, a history of physical, verbal abuse, all of those traumas that come with us into our adulthood that disenable us to cope with significant life events are really the hallmarks of what we've started to do with some of these patients. And of course, the physio and the rehab component is important. We certainly follow those neuropathic pain guidelines when it comes to starting patients down the road of being on the right medication, not 18 months after their surgery, but within that first 6 to 8 weeks if they have those 2 neuropathic pain symptoms. And if a patient tells you within 72 hours that one, they have these electric shock burning like symptoms that aren't going away and are using a copious amounts of opioids, they're set up for a problem. And we can see those individuals early enough. And the pathway for these folks before we built this program would have been to land either with their surgeon for a few months saying it will get better, or the family doc, and then ultimately get a referral back into a tertiary care setting, which may be 18 months after that initial surgical event. And so we've closed that gap from about 18 months to weeks. In terms of those psychological interventions that we talk about, the ACT-based therapies, clinical hypnosis, things of that nature, we have no doubt that all of these things are able on their own to reduce patients' intensity, unpleasantness, reduce their opioids, and overall improve the pain interference and the consequence of what's happening to them. We have a clinical hypnosis study that we've just wrapped up with some positive results, and we're hoping to publish that this year. We have ongoing work in terms of gentle yoga after surgery, things of that nature. I'm going to share with you a couple patients, and then we're going to dive into kind of the tech piece and the mobile piece that Don highlighted early on. And this is a gentleman that came in to see us. He was actually one of the top level chef. He was very good friends with the chief of police of Toronto at that time as well. And I can tell you that he had a pretty minor surgery. He was in there hammering away at his PCA. And we simply went into the room. This was one of my first fellows. And I said, sir, what's happening? Why are you using, so much? And before I could finish my sentence, his wife broke down in hysterical tears saying, Doc, we need help. And, my husband's purchasing $200 to $300 a day of illicit opioids. And, we need to do something. And so sure enough, we took him into the program, and he landed on Suboxone or buprenorphine naloxone several weeks to months later and did relatively well. Here is a gentleman, his name is Mr. Ross. He's a gentleman who has had over 13 surgeries for IBD related issues. He came in to see us in tears to the point where he said to us, I don't see any point in living anymore. I was even in hospital and I was asking for help. And they said, there's not much we can do for you. You're an addict. And this gentleman has never bought an opioid on the street. He simply, as a consequence of the way we were treating pain, was ramped up on his opioids and was now on a regimen of 30 milligrams of subcutaneous injections of hydromorphone every hour to 2 hours as a way to treat his pain. And it got to the point where his children said to him that, Dad, we can't bring our grandkids here because God forbid they're going to see you injecting yourself. What message are you sending? And sure enough, over time, we were able to talk to him about a move again onto buprenorphine naloxone. This gentleman has done fantastically well. He has just had surgery at Humber Regional Hospital and used the mindfulness techniques, not a single opioid, for a laparoscopic procedure. So, just some of the success stories. And I'm going to play a little video so you can hear through his own words the experience that he had with us.
I was prescribed opioids, in my case hydromorphone, self-injected, because I was in chronic pain following multiple surgeries over the course of the last 12 years. No, I'm not a junkie on the street. I get my prescriptions legitimately. However, over the course of the years, I realized that hydromorphone was not treating my pain. All it was doing was dulling my life and making it very, very difficult both for me and my family. I needed a different way to manage my pain. I needed to find a different solution to my problem because I wanted to rejoin society in a normal way and not have everything fuzzed over. I know that I will never be able to get rid of my pain entirely, but if I can manage it, I can continue living properly.
And so you can see there that once patients actually realize that there are multiple ways to manage their pain, medications are certainly one. Your brain and dampening down that nervous system signal, as well as exercise, etc. That is the hallmark of ultimately the effects of multidisciplinary care. This is a publication, again, that was just put out in late fall of last year. Again, at the time where we went virtual, we had a lot of these individuals that we couldn't do, in-person Suboxone conversions, in-person, weaning really successfully. So we put this paper out there for anybody interested to do an at-home Suboxone induction. And so literally have that person go to their pharmacy, get their induction meds. We used to do this as an inpatient and now do this over the phone. We just did one with a recent liver transplant patient who had the hallmarks of opioid use disorder and was really struggling in her home life with her young kid, etc. And most of the time it goes very well. And so again, adapting to this kind of virtual environment was key. This was probably one of our biggest wins. Was we partnered with a third-party app, and this was done in about 2019. I won't tell you how long it took to get through all the paperwork and the legal aspects to have this association with this third-party entity. And when COVID hit, as a consequence of having this pre-existing agreement, we were probably one of the first, or one of the few clinics, I should say, that were able to flip our entire database to a virtual kind of database connectivity. So patients can use this. We can get the information as we would have at an inpatient visit and use a lot of the questionnaire data in our database without missing those individuals and an inpatient perspective. I will tell you though, consenting is a big issue in this switch, because you still need, for some reason, wet signatures and things of that nature, which I hopefully we can move forward from that. And that has been a bit of an issue. But beyond that, we are actually able to capture the data we need from a clinical perspective without that patient sitting in front of our clinic and filling out oodles of paper. I will tell you, based on that, where we started in terms of that 0 to 9, I almost never ask my patient what their number is. I simply want to know if what they did in a day mattered to them and how much of what mattered to them they were able to accomplish. And that's the yardstick by which we're going to measure success as we move forward. And so, having this interaction virtually now via this app, etc., has been a win in terms of, patients can be at 2 a.m. sitting in their bed and giving me data. And when they come in to see us in the clinic, they'll often say, "Doc, did you look at that data I gave you?" And I'll say, "What are you talking about?" And then they won't leave until I actually go in and look at their data. And it's empowered them to have those discussions and move some of these discussions forward in those clinical encounters. We published an engagement paper about this integration of this app not too long ago. I think it was just out again in December, if I'm not mistaken, of 2020. And we have this paper that was accepted just last week, whereby we then looked at this engagement, not just in our transitional pain program, but we included it in, I think, Anuj Bhatia's neuromodulation program. We had a northern community in Iroquois Falls. In Iroquois Falls, many Indigenous patients are traveling a day to just see their physicians and have an interaction. And I can tell you what was interesting when we looked at the engagement in the urban versus the rural center, that we had maybe 30% engagement in the urban centers, i.e. our clinics, and almost 70% engagement in the rural settings. And I think that's a place where rural telemedicine, et cetera, will continue to grow and continue to show value. Think about these patients that can have communication with their physicians and the team from their bedrooms, their living rooms, et cetera, and data going back and forth. And so really cool stuff, I think, as we move forward. And what we eventually saw, and the reason this paper got published, was that an overall reduction in anxiety early on. And obviously, as you start to self-manage, and that is ultimately the goal for many of these patients, is getting to a place of self-management, that their anxiety, their catastrophization around their pain, all of these things reduced over time. And that should hopefully be up on PubMed in the next couple of weeks. I'm going to quickly go through this paper because it really speaks to that opioid weaning piece, and part of the reason our funding was granted to us, I think, at an ongoing long-term basis. You can see all the people involved in collecting and the work and seeing the patients, and this was just a snapshot of about 250 patients that we saw post-surgery. Most of them were picked up by our APS team, and that the connection between APS and TPS of about 120. We had a few patients pre and several patients post. And what table 1 shows you is that, as you might expect, there were more women than men with a pain problem, and that speaks to the literature. The recreational drug use population, a little bit higher in the opioid experienced folks. When you look at chronic pain, about 80% of those were a pre-existing chronic pain. And I think it speaks to about 19% of these patients being transplant and lung patients in particular, where opioids are prescribed for dyspnea. And so that might be that 19% there. And just to show you that these are typically complex patients at Toronto General Hospital that we're dealing with. This x-axis are the opioids that they left hospital with, and that magic 90 milligram number that's in the literature that patients should be on. And the y-axis is the dose they were on at 6 months. So that little square that's green now in front of you is in an ideal world where everyone would live less than 90 when they leave, less than 90 at 6 months. But you can see with these green circles, these are patients that walked out of the hospital over that number, and our program was able to bring them back under that number. And these are people that were never on an opioid. So remember that. And then there are obviously going to be outliers that, struggled and their opioid doses went up. And so that's that opioid naive picture. When you look at the folks that came in on opioids, you can still see a similar story there of many of them being in that perfect lower box. Again, we were able to reduce many of them under 90, but there are some that started above and continued above. And there's a bigger cohort here that we just weren't able to bring under that 90, but you can see many of them hovering in and around that number. And so again, one of these signals that what we're doing is actually helpful for these patients. And so, what's the moral of the story here with some of this data? And I can tell you that, again, when you look at someone walking in on 0 milligrams, the folks that came to see us were those that walked out on over 100 milligrams of opioids, never being on an opioid as a consequence of their intervention. You have those opioid experienced people that doubled to about 140 milligrams. And ultimately, what did they look like from a weaning perspective, which is what people were interested in. So I think that the number that really strikes me is if you look at that opioid naive experience next to the green box, where you see 25% of this small population that decided that even though they came in on an opioid preoperatively, the opioid was not necessarily what they needed to cope moving forward for their life. And almost 80% of these folks were reduced greater than 50% of the dose that they walked out on. And unfortunately, there's always a population that goes the other way. And I think we all know that the young male individual in particular is at high risk. And so I have some not great stories about some of those individuals that we had some interactions with throughout the program. The number one take-home message is that remember, when they're in our institution, what they leave hospital on will predict whether they're able to wean. And so the more we can do, and it's really a plug for my anesthesia colleagues, to keep individuals at a reasonable dose of opioids, use neuraxial anesthesia, regional blocks, multimodal medications to keep that number low, it will be successful. In those that already were on an opioid, the folks who do poorly, there were no surprises there. If you have significant catastrophizing issues, if you have significant neuropathic pain issues or history of recreational drug use, those are signals that you're going to struggle to lower your opioid doses upon leaving hospital. And so the final question is, that's great, you're able to wean these folks, but what do they look like from a pain and a pain interference standpoint? And you can see from these two bar graphs that they're actually doing better from a pain perspective and doing better from an overall functioning perspective. And so we've been quite fortunate. We've been granted some Health Canada funding to complete a 5-site randomized controlled trial across the province. Hamilton, Toronto General and Western, Thunder Bay, and Scarborough Hospital are all involved in hopefully getting to the bottom of whether or not this model of care actually has the outcomes that we saw in some of that pilot data. And I can tell you the cat's already out of the bag. These types of transitional pain programs are being built across the country. Alberta is putting this into their provincial funding pain strategy, et cetera. And so you can see that hopefully the RCT will help with some of that closing of or putting the cherry on top. So what are the current facts, folks? And I'll tell you, when you look at opioid-related deaths in 2019, so let's step back pre-COVID, 1,500 across the province, okay? When you then look at the Canadian number in Ontario, just in the first 3 months prior to COVID, you had about 1,000 opioid-related deaths. In Ontario now, from January to May, you're looking at 900. So we're well beyond that halfway point. And we were going to blow out that 1,500. And until the fall, and this is where we had some significant real dialogue between folks in the opioid harm reduction world and the government in terms of the way they were handling COVID. When you think about how we have been taught or being told to handle COVID, you must isolate, you must be by yourself, you must not ever, come in with contact with anybody outside of your bubble. And the hallmarks of keeping people alive from the harm reduction were the complete opposite message. One, please use in groups. Make sure someone is using with you. Have naloxone kits around. And so the numbers were going in the complete opposite direction. And only during our second wave, and we all know now that we're well over 6,600 deaths in Ontario, but as of the fall, the opioid-related deaths in Ontario were still outnumbering the COVID-related deaths, and that's probably because we locked down significantly. So no one's going to claim that that's the case today, because we have clearly blown the number out of the water in terms of COVID-related deaths for obvious reasons. I'll tell you that just from a program perspective, and this was the frustration, was we had seen 3 to 4 suicides in our program from March to about I think it was October. And this was really starting to weigh on us, obviously. And we had 0, in 3 to 4 years leading up. And this, again, speaks to that isolation piece that many of these folks are dealing with as a consequence of losing their in-person services. We had our physiotherapists doing all, they were redeployed in that first wave, et cetera. And folks literally that had community resources, they all just disappeared. And so, what were we going to do to try to help with this? And so, given I've kind of painted the picture that we have this virtual component, we're able to reach out to individuals. We've obviously always had telemedicine and OTN. We decided that one of the things we're going to do is we're going to apply for a grant to then go after all of these folks that are sitting at home and screen them for their suicidality, anxiety, and depression scores. And those that hit those high cutoffs will then be brought into a stepped wedge program. And that's what we're rolling out in our transitional pain program and our Ehlers-Danlos syndrome clinic that myself and Dr. Nimish Mittal and a whole host of others are working on. And these are folks with very complex medical issues and very complex psychosocial issues that are literally sitting in isolation now. And for some of them, I'll kid you not, they say, it's okay for me to be in isolation because this is the life I live now. I think the rest of society is feeling what I have felt for the last 10 years of my life. And so there's a spectrum of patients there. Some are doing worse and some are potentially actually feeling relieved by the COVID. And so we have, hundreds of patients. We're looking at about 200 patients over the next 6 to 8 months that we are going to be servicing with respect to that grant. In the last 5 or 6 minutes, I'm just going to talk about some of what we're doing on the cannabis side. And so you can see, all of these conditions and where we think we land. Unfortunately, the government, now we're spending upwards of $200 million a month on cannabis-based products. This is a population number. It was $40 million pre-2018. And there are specific areas where people and patients in particular are gravitating to. And let's be clear, we're completely stuck in this space because Health Canada and not a single industry maker of these products has ever gone down the preclinical tox pathway to enable a Health Canada approved condition. And so we, all across the country, we have protocols sitting that we can't move forward in some of these areas. And that's the bar graph there showing you the exponential expenditures by Canadians in the cannabis space. And so $200 million probably will continue to increase. We have some work out of the orthopedic and the MSK group to show that 1 in 5 individuals presenting to the operating room are consuming a cannabis-based product. We recently published some guidelines in and around perioperative cannabis care. And so this is a continued program of research. We were lucky enough to be given one of these team grants, and you can see all of the individuals across the bottom there that are associated with this. And I can tell you that when you look at kind of this overall interaction in terms of cannabis patients living with osteoarthritis, that we're just at the cusp. The animal research has started. There's some really cool findings looking at chondrocytes, and I won't give too much more than that, but really exciting animal-based stuff with Mohit and Jason and Tim, Lakshmi, and Anuja. A whole bunch of these individuals will be collecting human samples, and we'll have some data that will be second to none. I'm going to finish up with, just letting everybody know that just because people are consuming these products, we really have no idea what's in most of these bottles. They aren't going down a specific regulatory pathway that we have assurances of what they're consuming. And one of the things we wanted to do was create a possibility of being the first to have a database to understand what is being consumed and what actually we're seeing from an outcome perspective. And some of you may have seen this on the intranet or in the press. We did launch a observational national study. It's not just a UHN study, whereby which any physician in the country can actually place a patient into our real world evidence portal. And what is that? It's a portal where you will be able to authorize, we can't prescribe, it's not a DIN product, so authorize a product for a patient that will have a third party tested top 5 phytocannabinoid listed on their bottle or actually on their product. And so I took a look at the database recently. It's fantastic. We'll have all of the cannabinoids associated with and what patients are taking. Patients will fill out baseline questionnaires 6, 12, and 6 months. While we get this data, those who stop taking it will also get the ability to fill out these questionnaires. So we'll have a control group, something that has been completely missing in this. For those of you that have seen it or want to understand a bit more, there is a website that we created called www.rwe.ca, mcrw.ca, and I'll have that in a couple of slides. But what this entire infrastructure does is it leverages that bit of blockchain technology. I know it's kind of a concept that's probably lost on us, but it's not blockchain in the terms of mining money. It's blockchain in terms of connecting all of the pieces in terms of what patients are using it for, what their phytocannabinoid content is. 3 labs in particular have become the labs that will test these products, and anything on that portal will be, we will be able to generate some of that data for a specific condition. So I've had conversations with even some of the folks at Sick Kids who would like to use it for their adult populations that they're still continuing forward with to get some data to then hopefully go back to Health Canada. So I think we're onto something really cool. The website that I mentioned has created 2 portals, one for patients, one for healthcare practitioners. It's been already approved both at UHN and at Veritas, hence the broad approval. And we have training videos for healthcare professionals, et cetera. I think one of the most exciting aspects, though, is I was also appointed to the board of the Canadian Consortium for the Investigation of Cannabinoids. And this has been a 2.5-year CME module in making, and we have just received accreditation by the University of Calgary to launch this. And the one thing that I'm going to have the ability to do for individuals interested in learning more about cannabis and being interested in putting individuals into our study is give you potentially the opportunity to have a CME with a link to what we're doing, and it's a modular type program, and so it's certainly on its way out. I'm just in the final stages of figuring out how this is going to roll out, but any physicians in particular interested in putting people into the portal can have access to the CME, and I feel I'd be more than welcome to chat with anybody that has interest in this moving forward. So I think, telemedicine is here to stay. Whether the phone part of our healthcare allowance by the government will continue is another story. What's certain is that, to be ready for future pandemics, we need to ensure that patients' healthcare and psychological care isn't completely abandoned, and that we are ready the next time around so that these things don't continue to be a problem. And with that, I'll open it up to questions, and hopefully you enjoyed some of that.
Well, I did. That was great. Thanks. I actually learned a lot. So if you do have a question, please put it into the Zoom group chat. We do have 2 questions there, so I will actually start with them. Are there associations between poor sleep quality and pain tolerance in response to opioids?
Okay, so there is no, Don, repeat that story. My screen disappeared on me here.
Yeah, well, yeah, mine just disappeared too.
Okay.
Let me find that. Are there associations between poor sleep quality and pain tolerance and response to opioids?
Oh, so that's a definite. And so in particular, when you see, and we've done a good amount of sleep data collection even in the perioperative space. And so one of the things that we know is patients sleep poorly in and around the time of surgery. And so folks with poor sleep are also associated with, the instance of developing a persistent pain or even higher opioid use. So sleep tolerance and poor sleep and pain go hand in hand. And the patients, even on the chronic pain side, if you can help them sleep, you'd be amazed at how much better they can function in their daily life.
Okay. With regards to the opioid crisis, are there any race-based data on these numbers that you presented?
So if any of you do decide to tune into that Canadian Pain Society webinar, we spent a good 10 minutes talking about race-based data. And one of the things that Canada has been awfully resistant to do is collect any form of race-based data in race-based data in general. And there's a catch-22 here. So if you don't collect it, then you don't have to worry about it. If you do collect it, then you have to act on it. And so what's interesting is that Ontario has just put out, I think in the last year, some key demographics that they have now decided need to be collected, and race has become part of that. And I know Kwasi has documents. If anybody would like to see some of those, they can be easily accessed moving forward. But it's been a problem from the Canadian standpoint of having a lack of race-based data. And so we are moving in the direction of collecting that, looks like in a positive way moving forward.
Next question. What EDI considerations did you take into account when developing your mobile app?
Great question. What I would say is when you look at what we're collecting and the population we're collecting on, we certainly collect things like gender, race, age. We collect across multiple psychosocial domains. We don't collect economic data. It's something that we don't collect, but we certainly have the ability to look at. Unfortunately, what Canada uses are these geographic and postal codes. And we have some work ongoing at ISIS. There's a paper coming out in the near future actually pointing to the fact that it doesn't matter what area code you're in, because the thought here is the lower SCS domains potentially have higher opioid problems, et cetera. And we're not seeing that at all. We're seeing that actually these problems are irrespective of your geographical location.
Okay. Are there clinically reliable measures of suffering? And do we understand the factors that predict when someone transitions from pain to suffering?
That's a good question. we have we have a pain resilience questionnaire that we've just developed. Not really the suffering concept. If anything, it might be the opposite. And it's not an area that I have done much research in, but there's certainly a correlation with suffering, and I think suffering really relates to things like, you know, previous trauma, previous stress, and how you can kind of navigate that from a behavioral standpoint and move on with your life. And so, you know, the more you are to land in that suffering space, clearly probably the higher risk you are to go on to not cope well with your life and fall off the trajectory you'd hopefully like.
Would you recommend cannabis for nerve pain, neuropathic pain? And where can patients access resources or information on this for discussion, for their own use and discussion with their healthcare providers?
So, you know, this is such a controversial question, right? And so what the entire industry has based cannabis on has been this notion that CBD is the miracle component in this plant. It's safe for all and everybody can consume it. I will tell you, I have been very surprised at some of the patients that have done well with a CBD only product, or folks that need a bit of THC. A lot of it has to do with, one, what's their history with cannabis use. So individuals that have been consuming this in the past recreationally, and you know, we have these recreational products now that anybody can access and start to use. And so I would suggest that if you are thinking about, you know, using cannabis, one, you do want to get it from a reputable source, so an authorized source. I probably wouldn't go into the, you know, to the average dispensary and pick a product there. I would actually ask for it to be delivered in the mail. And THC for neuropathic pain, and that's the thought. I will tell you that there is some evidence that suggests that it is helpful. We just published a paper looking at about 1,000 individuals that came through cannabis clinics in Ontario, of which 300 of them stuck with it at 6 months. And people say, hey, well, where did all those patients fall off? And I can tell you, you show me any drug except if you're in the biologic zone, where only 1 in 3 individuals stick with it. And that's a pretty good, powerful response for individuals. And that's what we're seeing. And many of those did gravitate to THC. Many of the patients that we see in the pain world have a mix of, you know, MSK, osteoarthritic pain, neuropathic pain, inflammatory pain, you know, visceral pain, all of these types of conditions kind of thrown together. And certainly there is a signal towards THC in these more complex pain conditions, and in particular neuropathic pain. But again, we just need some better data to make firm conclusions.
That was an excellent talk. A population that may have a lot of challenges with opioid may be people experiencing homelessness. Could you comment on how these activities or app-based assessments may help this particular population?
Well, it's actually, you know, one of the things that I'll give UHN credit is that they've now started to take a look at this homelessness piece. And many of the patients that we often inherit sometimes are patients that don't have family doctors, or potentially can be, you know, living from shelter to shelter. And it is a challenge to care for these folks, given the environment they're in, et cetera. And so you know, and the app-based data collection for some of these is a problem. And it's been a big criticism for some of the work that we've been trying to move forward, because we can't fix that issue that if you are homeless, or if you are of, you know, quite low SES, that you're not potentially going to have a stable mobile phone and be able to access some of these things. So as much as it has been helpful because of the transition of care to virtual, it has been a bit of a barrier to those, you know, at the bottom without the access to this. And so it's a double-edged sword.
I will just point out to the audience that Maggie has put in the group chat the URL for the webinar that Hans has been mentioning, so that you can access that should you wish. While we just wait for any other questions, I will pose a question. I mean, I see a lot of patients with epilepsy, and some of them have migraine, some of them have neuropathic pain, and 1 in 5 of them is using CBD or CBD plus THC for their epilepsy. I frequently get asked, are the qualities of migraine pain and the qualities of neuropathic pain, are they similar? And what is the CBD THC role differentially between neuropathic pain and other types of pain such as migraine? And I stare at them blankly. So it's now your chance to prevent me from having that facial expression.
So, Don, there's certainly a theory in terms of migraine and endocannabinoid shortage. It's certainly been postulated that there is some type of deficiency in the endocannabinoid system with folks that have migraines. You know, and you do see, and in epilepsy in particular, it's dangerous. When you talk about cannabis in general, we know it's a potent CNS depressant in general, and the mechanisms are quite different when we're talking about the CB1 versus the CB2 receptors. And so everybody that is looking at cannabis and studying this, and that's the beauty of this new CME that's coming up. We really have some of the leading researchers talking about all of these conditions and the potential pathophysiology related to migraine and pain, related to neuropathic pain. And, you know, ultimately, we are still stuck without good inputs and knowing what people are taking to say whether or not we're seeing some of those outcomes downstream. And so in the CBD for all type space, you had patients starting to take any product they could find and either, you know, slowly lowering their anticonvulsants on their own and having some poor outcomes, which I'm sure you've seen.
Yes.
Over time. And so we don't have a clue about dosing these products yet either. And so somebody taking a 0.5 ml of a magic CBD solution under their tongue is completely different to someone taking 600 milligrams a day. And even that understanding in the lay public is completely lost. And how do we dose, you know, what is an appropriate THC dose? We know that if somebody is completely naive, taking 3 to 5 milligrams of a THC product is going to make you high. You know, somebody that's been using this ongoing, 20 milligrams might just be giving them that CNS depressant effect that they're looking for. And so, you know, the cart is well before the horse, and we're just here trying to hang on and bring the science to this discussion over the next 3 to 5 years, to be honest with you.
All right, I'll just point out that Karen Davis has also posted something in the group chat regarding the webinar Hans has mentioned. The CPS webinars are free to CPS members and those who are registered for the webinar, but $50 for non-members. So there are no further questions in the chat. So with that, I will draw this hour to a close. And I will thank you for your well-timed presentation. We're coming in on time, always appreciated. That was, I will echo what is appearing now. Excellent talk. Thank you ever so much. We appreciate it. And we look forward to your continuing success in this important research. Thank you ever so much. And goodbye to everybody.